The molecule doesn't know why you are taking it. Like, it's not a
Right.
sentient being. You
Yeah.
can't talk to it. You can't say, hey, I'm taking you today for weight loss, and tomorrow I want you to help with my blood sugars.
In her parents' living room in Crown Heights, there was always a stack of paper, prescriptions. Some weeks the pile grew, most weeks it didn't move. School uniforms, tuition, groceries. Those came first. The medications waited. But the thing is, no one at the clinic ever asked whether they'd been taken. Janelle Duah was a kid then. She's a doctor now. And decades later, in cities all across the country, she's watching a different set of families quietly reorganize their budgets, all to afford a weekly injection that in many cases their physicians won't prescribe or their insurance won't cover. The medication is a GLP-1, a relatively newer class of medications, but the pattern of people struggling to afford new therapies is older than the molecule. That's what we're here to talk about today. I'm Dr. Neel Shah. Welcome to the Preprint. Janelle's path to medicine started in part in another exam room. She had congenital heart disease as a child, and her appointments at Mount Sinai looked nothing like her parents' visits a few miles away in Brooklyn. By 6 or 7, she already decided to become a doctor. She trained at Yale, did a residency at the VA in West Haven, and she realized that residency taught her a lot of things, but not a whole lot about obesity or the lifestyle challenges that impact health. So she went and got fellowship trained. She got triple board certified in internal medicine, obesity medicine, and lifestyle medicine. Today, she's a medical director at Maven, and I get to work closely with her. And she tells me obesity runs on both sides of her family. She has PCOS herself. And the GLP-1 conversation that we're about to have is one that she's had with her own body, her own physician, and thousands of patients. So let's get into it. Janelle, I know you grew up with humble means, and I just told everyone about the stack of unfilled paper prescriptions that were piled in your living room. What I didn't tell them was what was happening in your own appointments at Mount Sinai, just a few miles away. Take me there.
So I believe I was having a completely different experience than my parents, and I could understand that and start to conceptualize that even as a kid. So as you mentioned, I had a pediatric cardiologist, saw them in Mount Sinai, and there things were drastically different than the appointments I saw my parents having. We didn't have babysitters or the luxury of that. I would go with them to their appointments. So of course I'm at my own appointments, going to my parents' appointments with them, and seeing that discrepancy and trying to reconcile that in my brain, even as like a 3, 4, 5, 6-year-old. So at Mount Sinai, I can always remember my cardiologist would sit down with the entire family, explain things, answer questions, would still make sure to play with me while engaging with my parents. He would make sure that my parents understood what had happened and then also what the next steps would be. So there was enough time, there was clarity. There's also a certain amount of like dignity, sitting down and explaining these very, very complicated concepts around congenital heart disease to my parents. And then I would go home and see the stack of prescriptions in our dining room table. That was back in the day when we did not do electronic prescriptions. You would get that prescription pad, you would get a prescription written out to you, ripped off, handed to you. And quite often, those never got filled. And I would think about why those weren't getting filled. In those appointments, there was little education, very little instruction, kind of just getting a prescription and saying, see you in a few months. So it was very hard for me to conceptualize like why there was this difference and that this difference existed when, again, this is all in New York City. We're seeing providers in our neighborhood, Crown Heights, Flatbush, the area around. And then I'm traveling to a more affluent part of New York City and getting the care that I wish that my whole family was getting. So that first created that discrepancy in my brain and actually pushed me, and again, as a little kid, into medicine. I'm like, what I get myself, I want everyone to get. So I was understanding that things were being prescribed and recommended, but not really received and thus not done. So that actually taught me that healthcare is more than prescribing. It's prescribing and educating to a person and their family and themselves as like a human in a way that is informed by what they can actually understand, access, and sustain. So that's really what pushed me into medicine and wanting to be a primary care physician in the first place.
I feel like it's remarkable to be that young and know what you want to do when you grow up. And then it's even more remarkable to have that split screen where you're like, not only do I want to be a doctor, but I know exactly what kind of doctor I want to be. And you're 7 years old. Okay,
Yep.
so now we fast forward, you're training, you're at Yale, You're taking care of veterans at the VA,
Yep.
folks who have a lot of chronic conditions that they're carrying. At what point did you realize that medical education had so little to say about obesity? And like, what did you do about it? What was the thinking there?
So I did my residency at Yale, and I specifically did our primary care residency because I knew from the get go that I wanted to be a primary care physician. And a lot of that came with wanting to empower people with information about their health, their bodies, and helping them to be advocates for themselves. So we were really good at managing chronic comorbidities that we see in primary care, like diabetes, hypertension, heart disease. And then as time went on, I would say like in my second year of residency, I'm like, there's a common denominator. All of these things are very deeply tied to weight, but we're not addressing the elephant in the room. We're not talking about obesity itself. So it felt like we were very expertly managing the downstream effects of obesity and ignoring that upstream driver. So that's when I was like, I really want people to truly understand what's going on in their bodies. I'm having an epiphany about what's happening in general. So I'm like, I want to get that to people out there, but our training did not support that. And again, like you mentioned, this really hit home for me because all of those kind of conditions that I mentioned run on both sides of my family. Obesity
Hmm.
and overweight run on both sides of my family. I was clinically obese from the age of 3, and I
Hmm.
have PCOS. So it wasn't just me learning about these things. It really stuck with me because I'm like, this is a way for me to help all of these people that I'm seeing, but also help my family and help myself. After I got my internal medicine board certification, that same year, I went ahead and got my obesity medicine certification. And then a year or two later, did my lifestyle medicine certification. So these are newer paths to getting to the kind of root cause analysis, but it does take sourcing it out and like that passion to go and pursue it because it does not exist in our traditional residency programs, even ones designed for primary care.
That's remarkable. I mean, first of all, there's not a lot of docs going to primary care these days. But then the
Right.
fact that you've got to blaze a path, to pursue lifestyle medicine and obesity medicine in a culture that's totally obsessed with weight,
Yep.
like what does that tell us
Yep.
about what American medicine actually values?
Multiple things. You mentioned that a lot of people aren't going into primary care, and I think that's because American medicine values fast fixes like
Hmm.
acute care, urgent care, procedures. The highest compensated specialties in American medicine are procedure based. And then you do, again, in that realm of acute care and urgent care, fixing downstream things and not taking the time to address the upstream things that have so many factors, biosocial, psychoeconomic factors that classically people think don't belong in the clinic room, but like these conversations are important to be had. So I think again, it tells us that American medicine is kind of focused on fast fixes to the detriment of conversation, relationship building, education, and then thinking specifically about obesity, that conundrum where like we are seeing ever growing rates of overweight and obesity. It is a little less stigmatized. People are talking about it in different realms here, like hair, social media, media in general. But American medicine is slowly catching up to the conversation surrounding it. I think one of the reasons is because still, like the Obesity Medicine Association came out with a definition of obesity, but still on the individual level, I think that there are still some medical providers that think of obesity as a cosmetic and behavioral issue and not a true illness or a condition, and thus don't feel empowered to learn more about it, to do more about it, to be informed about it, rather kind of just chalking it up to willpower and behavior.
Yeah, that makes sense. I mean, but also, it feels like we kind of do have a quick fix now, or at least it seems
Mm,
that way, and most people know what GLP-1 medications are from the headlines, which has made it feel like they came out of nowhere.
right.
I'm curious when you first became aware of these medications and why did we only start talking about them a few years ago?
So I personally knew again from doing primary care residency, treating a lot of diabetes, especially type 2 diabetes. I knew about the medications kind of coming in. We started to learn about them in I should say medical school, but then really started prescribing in residency, but that was in the realm of diabetes. So even though it seems like these GLP-1s just jumped onto the scene, they've been around since 2005. I believe the first GLP-1 that was FDA approved was exenatide, which is the brand name, I think, Byetta. I think what has changed more recently is not that they exist, but that we are more invested in understanding all that they do. So like we're using higher doses. There are more than just exenatide available now. And as we are using them more, using higher doses, we are seeing more expanded data about what they can do besides weight loss. That's the next thing that they came about for or were FDA approved for. Then we started seeing cardiovascular benefits, and now we're seeing it almost body wide, like impacts on way more systems than we thought classically when they first came out in 2005.
You were telling me like a couple of weeks ago that GLP-1 receptors exist on every organ in the body,
Yeah.
which I think a lot of people don't know. It's like the brain, the pancreas, the ovaries.
Yeah.
And why are they everywhere? And what should that tell us about what we're really treating here?
Yes, it's so cool. So as I started learning about these and trying to understand, okay, this one medication that we thought did this is doing all of this. Like, how is that happening? So like you said, there are widespread receptors even in our lungs, like they're literally everywhere. So I think it helps us to understand that GLP-1s aren't just an insulin hormone or a satiety, like helping you feel fuller faster and like all the things that we classically describe when we are explaining how these work. I think they are like potent body-wide mediators. They're linking systems that we don't classically put together into one whole body kind of environment, like they're master regulators. So I think what we've classically thought of as metabolism actually touches everything, like every single body system is involved in what we think of as metabolism. So it's not just about blood sugar, not just about weight. Literally, it's about integrating energy balance, appetite, insulin, your brain thoughts about food, even reproductive function. Like this plays a role in like the GLP-1 molecule, and our pharmacotherapy based off of those molecules plays such an integral role in our body from like head to toe.
I mean, you said something to me in our pre-conversation that I can't stop thinking about. You said the medicine doesn't know what you're taking it for. I mean, what does
Yes.
that mean, and why does that matter for how we understand this moment?
I feel like sometimes when you let people know, hey, these medicines have been around since 2005, we have like 20 years of information and data about them that people are like, yeah, but we weren't using it for weight loss then. The molecule doesn't know why you are taking it. Like it's not a
Right.
sentient being. You
Yeah.
can't talk to it. You can't say, hey, I'm taking you today for weight loss and tomorrow I want you to help with my blood sugars. Molecules mimic natural ingrained pathways in our bodies, not diagnoses. So the molecule works the same way dependent on which receptors, the density of receptors, how often they're working on the receptors. So the receptors are everywhere. The medicine attaches to them. It doesn't know that it's attaching to it for one particular reason or not. It's just our biology and how we are mimicking biology in a way that actually sustains the benefits, that helps us to see these widespread differences. So the molecule doesn't know why you're taking it. It's just working.
Right. And, one of the areas where you and I have collaborated where our expertise comes together is writing GLP-1 protocols for things like PCOS. You have PCOS. PCOS
Yep.
is polycystic ovarian syndrome. As an OB/GYN myself, we don't know what PCOS is. Syndrome means we don't really get it, but it has something to do with metabolism. I'm curious, as someone who both is experiencing PCOS and has this deep expertise, how much of your clinical lens comes from being the patient before the prescriber?
Yes. And I think that in my career as a physician, a lot of it is personal based. Like I wanted to come into primary care because of what I saw with my parents. And then I wanted to get into obesity management because of my own struggles and my parents' struggles and those around me. And then it's like I see it happening to myself or my family, do research and see that it's impacting way more people than I thought. So like my interest in will not only help myself, but also variety of patient populations at large. So I think that being a patient has given me a passion and a drive to fix these things, to educate about these things more than just like, oh, this is cool and reading it in a textbook. And particularly with PCOS, that was another driver for me wanting to get into my passion for women's health. I was diagnosed with it when I was 16. I'm now 36. So I've lived more of my life with this diagnosis than without it. So it really pushes me and to understand more about it because I have that lived experience of doing everything right, like eating well, exercising, not exercising too much, sleeping and prioritizing and feeling like your body is rebelling against you.
Right.
So I have that fortunate or unfortunate experience that makes it like when someone comes in with that diagnosis, I'm like, okay, I know what you're going through. So I really am driven to help you feel better within your body. And I think GLP-1s, especially in the PCOS space, is very exciting because, again, we were talking about how these receptors are on multiple parts of the body, multiple organs, affect multiple organ systems. Like you said, PCOS is a syndrome, meaning we don't know exactly the root cause. There's possibly many types of PCOS
Right.
that have
Syndrome means
different
we don't know.
Exactly.
Yeah.
So it's like for those sorts of cases where we see GLP-1s working in multiple different ways where it's exciting. So again, these receptors are everywhere. There's a lot of emerging evidence for use of GLP-1s in PCOS. The biggest reason is the weight loss. We think a lot of things that happen with our insulin resistance, testosterone levels are affected by weight. So we see there's some research that shows that helps with BMI, waist circumference, which is kind of like a surrogate for visceral adiposity, like overweight and obesity that actually affects organ
Right.
function
That's
and
like fat around
dysfunction.
like your heart and stuff, right? That's what you're talking about.
Exactly. We see
Yeah.
that being improved more than metformin, like compared to metformin, which classically has been the like metabolic enhancer that we use for PCOS. And then we see also that besides weight loss, we get better insulin sensitivity. We see better or reduced testosterone levels. We see increased sex hormone globulin production. So helping to like not only the level of these hormones, but how they move around in their body bound and actually affect function. And there's emerging evidence about fertility, like the GLP-1s are hitting
Helpful.
the receptors on
Yeah.
ovaries, like
It's helpful. I
helping
mean,
there
like,
too.
you just go on like any online source and
Yep,
Ozempic babies is a trending topic, right? But meanwhile,
absolutely.
clinicaltrials.gov has the trial for PCOS and GLP-1s. And I think that they're not going to be done and ready to publish results until 2030. And at the same
Yep.
time, people are like voting with their feet. You talked about visceral fat or like fat around the heart or the liver or
Yep.
something like that. You told me a story where a cardiologist tells one of your patients who had a prior
Yep.
stroke and was legitimately benefiting from GLP-1s to go eat a salad.
Yep,
And
those
like,
were the very words.
well, how does the cardiologist get there?
Again, as a whole, medicine is moving towards a more scientific understanding of obesity, but it is always tinged on the individual level with an idea about it being like an outdated model of obesity, about it being about willpower and behavior. So she's on a medication, right? But he suggested a behavior, a lifestyle change, a change. So I think that it is still that tinge of stigma and like personal responsibility over what we know is biologic. But I think also just thinking about the different physicians that I have seen have this kind of idea around GLP-1s, that is also some discomfort. So like if you feel like you don't have the training, you don't know much about these medications, and you also aren't driven to learn more because you think that they are being overused, like you already have your own biases around the medication, you are meeting patients in a space where they might know more about the medication than you. You have no desire still to learn more about these medications and be more informed, and you're falling back onto the outdated model of like obesity is your problem. You are a bad person because you are obese. So I think that's how we get into this place where because you don't believe in the medication, you don't want to learn more, it's easier to dismiss and demean the medication than to actually want to serve your patients and learn more about them.
Yeah, I mean, you said something interesting. I think patients are increasingly very informed about GLP-1s and they're at least seeking the information out and they're learning and they're going to
Yeah.
doctors and they want their doctors to validate that information or share more. Part of what you're describing is what happens when patients show up with education from outside the office in the first place.
Yeah.
What is it about a knowledgeable patient that destabilizes the physician, Janelle?
This may be a little spicy,
Go
but
spicy.
I think that the basis of why some physicians, I'll qualify it with some, don't like knowledgeable patients is because it shifts the power dynamic. Like medicine has been historically structured around the physician being like the know-it-all. They're the gatekeeper of information. They're who you go to get your prescription. They are the ones who diagnose you. They're the one who gets you to someone else if they can't diagnose you. It has been thought of as patriarchal for decades, and now we're shifting towards like shared decision making. But even within that model, it's still like I'm the provider. I am providing the knowledge, and then you provide me your lived knowledge, and we are making a shared decision about it. So even in the framework of shared decision making, taking, it's still that the clinical know-how, the evidence is like coming from the provider. So when people come in already knowing the research, like you can go on PubMed. You can chat GPT, you can use open evidence. When people are coming in informed, asking specific questions, pulling out research. Did you read the New York Times article on this? Requesting specific treatments. It's like, oh, you think you know more than me? I'm the one who went to medical school for this many years and did this training. So it shifts the power dynamic that is somewhat ego-based. And I think that a lot of physicians don't like that, but I think it's actually an opportunity for partnership. If someone is coming in and they already know, then you have a fruitful discussion. There are going to be some places where you know more. There's going to be some nuance to the discussion. I think that an informed patient should help us be more partnered with our patients and keep us accountable and force us to be better instead of like being like, oh, you think you know more than me. But I think that's what a lot of people devolve to.
I mean, I think it feels more complicated as the doctor when the patient comes in and you're not the single source of truth and there's a lot of information. And honestly, a lot of that information is like garbage. You know, some of it's good, but either way, the idea that patients are going to come in with sources of information that did not come from their doctor's office is just our reality. Right. And we have a word for it. Like medicine describes patients who arrive asking for something specific, specifically a specific drug. We call them seekers. And it's almost always pejorative, right? So are we entering an era where a seeker just means informed patient? And what do we do with that word now?
Yes, I agree with you. And the example that comes to my mind is of like someone who goes to a pain clinic or the emergency room with pain, and they are a pain med seeker. They're an opioid seeker. Like they're seeking something that they shouldn't need or that is bad, that they shouldn't have. But it's like now, it's like we're talking about all the great things that GLP-1s do. So most of the time they are seeking something that actually is probably appropriate for them with some misinformation, like you said, but likely could be helpful for them because we're seeing, again, head to toe benefits for the GLP-1s. So I think that some of our discomfort with informed patients or people who are seeking, like someone who comes in and is like, I want Zepbound 2.5 milligrams because I read this. As someone who does primary care and is always about getting the backstory, you kind of have to work backwards now. Usually you would come into the room, you get your what you call the HPI, the history of present illness, right? So you go in, you start asking your questions, you're making your differential in your brain, like you're working through a path, an algorithm, but it's like you got to start at the end and move backwards, which can be uncomfortable for people.
And it takes time.
I need my Zepbound. Yeah, it takes a lot of time.
But Janelle, here's the thing. I want to do the work, right? Like I want to work backwards, understand people's context. And you have given us the deep dive into GLP-1s and all the things that can do well beyond what we might even imagine. But GLP-1s have also opened a door, I think, to a broader like peptide wave.
Oh gosh. Yeah.
Right. Yeah. Oh gosh. Right. And it's like it's like wellness culture grafting itself onto pharmacology. Like where does that go? Like, are there limits to this?
Yes. And I think that what we're seeing, this blend of medicine, I should say evidence-based medicine and wellness, which is not always evidence-based, is such a hard place to navigate. And I think it's exciting because people are, again, more engaged, learning about health, learning about their bodies, but also risky because a lot of this information is misinformation. It's coming from influencers, people who did not get many kind of medical training. They're just hopping onto trends a lot of the time. So then you see wellness being grafted onto evidence-based medicine in a way that can be unsafe and often lacks clinical oversight. And again, is often based on trends. So I think that for a lot of platforms that are out there, there is that balance that's not being balanced, that there is more of the trend and wellness and let's compound everything versus what actually makes clinical sense. What is FDA guidelined and recommended? What is the research even showing? So I think this has created a space for multiple platforms that do multiple things. People are getting more access, but there's still a tinge of unnecessary exposure and risk when there is lack of clinical oversight.
You know what I think? I've always thought there's like this Venn diagram in my head, and like healthcare with a capital H is one circle and wellness is another circle. And it's like a spectrum, right? Like healthcare with a capital H on one far end is the Mayo Clinic. And like wellness, the other far end is like Gwyneth Paltrow, you know? And you know, like I've always wanted Maven to be in that intersection in between.
Right.
Like, we're not going to do jade eggs at Maven Clinic.
Thank God.
Right. And we're not going to build like proton beam therapy. Right. But like,
Right.
I think people probably deserve support with both. And we've got to find that balance.
I agree. And I think that, again, that balance is key. In my own career, with having to kind of educate myself and then finding platforms for further education that is like board certified, I have learned a lot. And again, it's not in our traditional residency training, it's not in our fellowship trainings. So I think that there is a definite space in that Venn diagram where, like, what we've learned healthcare wise, capital H, can be combined with what we seek out with wellness. There's medicine and evidence for that overlap. But I think that the way for platforms like us at Maven, where we're trying to be that intersection and provide clinical oversight, is that we have to have systems in place, like systems that prioritize safety, prioritize evidence, has guidelines and guardrails, and also focus on longitudinal care. Like, we want to build relationships. We want people to feel safe with us. We want people to actually give us the information that we need to find what is appropriate and safe for them. Like, we really want to have people be informed, understand the emerging evidence, that there's some places where medicine is still catching up, but we do have research, and like be that place, that safe space, literally, where people can learn more about their health, learn more about their bodies.
But I've got to tell you, that sounds great. And it sounds almost too great, you know,
Right.
because I like, you have, since you were 6 or 7 years old, had total clarity on what good looks like. And you've been working towards that for decades.
Yep.
Most people who are uninsured or on Medicaid, like 75% of them, are obese. You have the highest
Yep.
rates of the exact conditions that GLP-1s are FDA approved to treat. But the platforms that are out there marketing directly to patients and trying to, you know, kind of bypass that really annoying incumbent system that we've been beating on this whole time, you know, they're asking for a lot of money, much more than a
They
lot of
are.
people can pay out of pocket. How do we understand that paradox? Like, how do we ultimately make this good care accessible to people?
Exactly what you said. We have this conundrum, this paradox, where the people that benefit the most from these interventions cannot access them because of financial barriers. We think about like the actual subscription or payment, but also upwards of 75% of people who are uninsured on Medicaid or Medicare have obesity. That same number also don't have access to reliable Wi-Fi or iPhones. Most apps are iPhone based, not Android. They might have flip phones or what we call Obama phones. So it's not even the financial, it's like the access to that thing. Like, sometimes they literally don't even have internet to be able to go onto the platform. So it's like the people that need it the most truly cannot physically access it in sometimes, but and also cannot access it because of financial means. So this kind of springing up of multiple direct-to-consumer platforms, I think, is actually contributing to the gap in care, because we have people who are now skipping their doctor, going to a platform, paying hundreds of dollars to get this prescription, where that is unfathomable for most people that actually need it. Or people are then having to re-budget their lives around trying to access these medications. And it's like, if you're budgeting differently, something is getting less so that you can allocate to this. And like, what is that something? It's something that
Right.
is important because it's part of your budget. It's something that you have to do.
Right. You've
But
lived
like,
this.
yes,
And we started the
exactly.
episode at your parents' like living room or dining table, right? And decades later, we're watching lower income families do the exact same math, like to your point.
Mm-hmm.
Only this time, you know, it's to afford this newer class of medications. And this is the part that to me feels like a tale as old as time. You know, like
Mm-hmm.
GLP-1s are new, direct to consumer medication as a trend and platforms, that's all
Yeah.
new. But that math, that's how it's always been. I mean, what's different this time around?
Multiple things I would say are different. So what's different is that I think that this is happening in a space where people have more autonomy and more potential access to different platforms. The medications are actually effective. Like, we are no longer in the days of fen where like you could lose weight but also have a heart attack. Like, we have medications that are actually surprisingly safe
Yeah, that's a
and
good
work.
point.
So people are more drawn. They're safe, they work, they're seeing it on media, they're hearing about it from their family and friends. So the drive to get these medications is high. So again, we're talking about the financial and true access issues, but people will budget. Like, in my own family, it was like, your school uniforms, your school fees, our groceries, that, and healthcare. Now it's like those same things our regular healthcare and my GLP-1 subscription. I don't know how we improve that. I don't It'll probably end up being we have to just be better in the true traditional healthcare system, whereby people who have Medicaid or Medicare or any private insurance are able to get the attention that they need, that they are felt listened and heard to, that there's enough time to do that in our traditional healthcare system, such that platforms aren't needed to fill in that gap.
I mean, like, you bring up a really good point, which is like 30 plus years later, like we're in a completely different technology moment. Like, what's different? We have a thing that works, to your point.
Right?
When we were kids, we remember before the internet, right?
Yeah.
And now we've got these platforms, right? Like that
Yeah.
can just, I mean, like what a time to be alive. And
Right.
also, to your point, I think the incumbent system has to be better, but I also
Mhm.
think like we need to merge.
Agreed.
Don't you think like it's
Agreed.
got to be both coming together? Like if we get this moment right, really right, what does primary care look to you in like 5 years?
This will go back to why I came into primary care in the first place. If we get primary care right, it's like its name, it's primary. Like your primary care provider becomes the person you trust, the person you go to first, the person that you can talk through your health with in a proactive, preventative way. And unfortunately, because things happen, a reactive way. Like they can help you be healthy, treat outcomes should things still happen, that people feel heard, listened to, paid attention to, that people see their primary care visits not just appointments, but like just a stepping stone along building the relationship with someone who can help you understand your body and your health. And that it includes not just medication, but ample time. Time is like one of the commodities that almost every primary care physician wishes we had more of with our patients. Time, that it allows the time for not just prescribing medications, but talking about how these meds work, why we're using them, lifestyle, education, and context. Like actually not just us talking to the patient, but the patient talking to us, like helping us understand where they're coming from so that we don't just give them one fits all like recommendations. We make recommendations that fit their life, their lifestyle, their household. So you're giving holistic, comprehensive care, which seems like pie in the sky, but good primary care physicians do this. It's just in a way where you're running late all the time. You
Right.
are up till 11 p.m. answering patient messages and doing
Well,
your
here's the other
charts. And then
thing.
there's burnout. So
Totally. But also, like, writing notes in your pajamas in 2026 is medieval now. Like,
literally.
like just in 1 year, we got to a point where, LLMs and ambient listening and all this. And one of
Hmm.
the, ironies here is that people are fearful that AI will make human connections harder. But in some ways, I
Yeah.
think they're going to make them more valuable.
I completely agree. Even on our Maven platform, I feel we have an AI tool where we use scribes, like an AI scribe. One of the key skills that I learned in residency was how to engage with the patient and still type or still write. But something else is doing that for me, my whole attention is to the patient. I can listen to them.
You and I, as we're building this thing out, as we're trying to figure out how to deliver services for things like GLP-1s or hormone care or other things on an online platform, we've created a couple pacts. One was no dead ends. Right?
Yep.
We're not going to leave anybody in the lurch. Maybe there's a
Mm-hmm.
new one too. As I'm talking to you, it's like we care about things that matter to you, even if they won't kill you. Because I feel like
Yes.
right?
Yeah, I like
Like
that.
it's like
I
we
like that.
care about just making you well, right? Not
Yes, and
just
making you happy and
right.
thrive and not just survive.
Right.
I think,
Right. That's a
yeah,
good pact. Yes, we're going to help you thrive, not just survive.
I like that. Let's patent that.
Well, we're both wearing our Maven sweatshirts today. Maybe we can like print that out on the next one.
Yep. That would be great. But yeah, exactly. It's not exactly. We're not just focusing on things that will kill you. We want to have you live an enriched, fulfilled life while we're here.
There we go. Can't put it better than that. And that's our podcast. That was Dr. Janelle Duah. She's one of the very few physicians in this country who chose to specialize in obesity and lifestyle medicine. After spending an hour with her, you understand why we need thousands more just like her. We started this conversation at her parents' kitchen table in Brooklyn. We ended it at the kitchen tables of families budgeting against a new class of medications that are transforming medicine and the health system at large. The tables are different, the math is the same. That's what the preprint is for. Not to tell you what to think, but to make sure the questions worth asking aren't getting lost in the noise. If you want to keep going, we're at mavenpreprint.substack.com. But first, stick around for required reading. A few weeks ago, the journalist Julia Belluz published a piece in the New York Times called The Great Ozempic Experiment. She had set out more than a year earlier to write a story about insurance gaps and the harms of a drug rollout that had outpaced the medical system. What she ended up with is something stranger. Belluz and her team surveyed 2,000 Americans on a GLP-1. More than 60% of them said that if the medication failed to help the condition that they were prescribed it for, they would stay on it anyway, for something else. People are taking GLP-1s for long COVID, for IBS, for drinking, for anxiety, for focus. The former president of Eli Lilly told her that diseases we have spent a century treating as separate categories, endocrine, cardiovascular, neurologic, may actually turn out to share root causes that we haven't named yet. Which is to say, we should probably stop arguing about whether GLP-1s are a fad. They're not the next diet pill, they may be the next penicillin. And we're at the very beginning of understanding what they actually are. That's The Great Ozempic Experiment by Julia Belluz in the New York Times. It is this episode's required reading. I'm Dr. Neel Shah. This was the Preprint. We'll see you next month. The Preprint with Dr. Neel Shah is produced by Maven Clinic in partnership with Pod People.